I got an email from Latimer. He's a paramedic in Milton, Vermont, and he asked me a question about some of the evidence about IVs versus IOs, and he did it in the context of his state medical protocols that are recommending IV access as soon as possible with epinephrine as soon as possible, including preferences over an IO. Now, I think it's a really timely question because it comes right on the heels of the release of the American Heart Association guidelines on managing cardiac arrest. And one of those guidelines, the one that you probably haven't seen because along with everybody else on all of the socials, you've been way wrapped up in the meme-driven discussion about, say, prying your Lucas from your cold dead fingers because the Heart Association says there was no evidence that it worked. Well, I'm not going to rehash the 5 recent episodes I did saying, well, as it turns out, the Heart Association is correct. There is no evidence saying the Lucas saves lives. And I'm also not going to point out that this is not a new recommendation for the Heart Association, nor am I going to point out that they very reasonably say there are some circumstances where you should use it. Like, say, if you have to, would recommend you don't, but if you have to transport a patient in cardiac arrest with CPR in progress to the hospital, or if you have limited manpower, then it's reasonable to use it. We'll just skip over all of that because nobody wants to say that the Heart Association came out with a reasonable guideline. I'll be first to say they came out with a reasonable guideline on this. I also just can't help but say they also came out with a very reasonable evidence-based guideline on Heads Up CPR. To paraphrase, they said it's not ready for prime time. They said don't use it in the outside of the context of a clinical trial. Very, very reasonable. Getting back to Latimer's question, he's really asking about the value of epinephrine and whether it makes any difference at all, and then whether it makes a difference given early versus late and IV versus IO. Which gets us to one of the other Heart Association recommendations. It's also not a new one that says IVs preferably over IO, and then if you can't get it in a reasonable amount of time or in a reasonable number of attempts, is reasonable to go to IO. That recommendation is reasonable based on some observational evidence. Evidence dealing with, say, antidysrhythmics that show they're more effective given IV than IO, and some hints on the same thing with epinephrine. Well, in this case, the Heart Association turns out to be premature. And what I mean by that is the timing of the release of their guidelines was unfortunate because as the guidelines came out, so did 2 randomized control trials in cardiac arrest of IV versus IO that I think fairly definitively answers this question. The 2 trials were the Paramedic 3 trial and the IV-IO trial. They come on the back of the Victor trial, which we've already done a podcast about. So what I want to do when we get back is talk about these 2 specific trials, Paramedic 3 and IV-IO. So Latimer, thank you for the great question. Let's see if we can shine the light of science on this particular question. We'll be right back, y'all.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of modern EMS clinical practice. So if y'all are wondering why my audio sounds a little bit different than it normally does, if you're wondering, if you're seeing this on the tubes of you, why it looks like I am, say, recording in a hotel room and why I'm wearing this odd sweater, well, It's because I am indeed recording from a hotel room. I'm actually in Iceland right now, and I'm on my 35th anniversary with my wife, Christy. We decided we're going to drive around Iceland and see what a cool country it was. And it turns out to be a gorgeous country. We're having a blast. We got to meet a couple of folks with the Icelandic EMS, and they got to show us what their system looks like. A lot of fun. I really, really recommend if you ever get a chance to come to Iceland, definitely do it. And the sweaters, incredibly comfortable and warm because, in the middle of October, early November, it's a little cold up here. This Texan needs all the wool sweaters he can get. Let's talk IV versus IO in cardiac arrest, shall we? So, two papers for you. The first is by Couper and colleagues, including Dr. Perkins. Dr. Perkins from the Paramedic 2 trial of epinephrine. This is the Paramedic 3 trial. The title of the paper is A Randomized Trial of Drug Route in Out-of-Hospital Cardiac Arrest. That's the Paramedic 3 trial. That's the first paper we're going to talk about. Then the second paper is by Dr. Vallentin and colleagues. This is Intraosseous or Intravenous Vascular Access for Out-of-Hospital Cardiac Arrest. This is the IVIO trial. Both of these papers were published in the same version of the New England Journal of Medicine 2025. This just came out. So let's jump into Paramedic 3. So Paramedic 3, much like Paramedic 2, was a multi-agency UK-based trial. It's a randomized control trial. This one is an open label. It's kind of hard to blind whether you're doing an IV or an IO. I think you're probably going to know which one you're doing. So this is an open label, pragmatic, randomized control trial. They did the analysis using adjusted analysis, using regression, and they did it in an intention to treat model, perfectly reasonable. The population they enrolled, these are adult patients in out-of-hospital cardiac arrest who need medication. So this excludes patients, all the Ps that you would expect them to exclude, the pregnant patients, those who had prior vascular access, and the pediatric patients. So the intervention is the first two attempts are with an IO. And if you don't get it after that, then you can do whatever you want to. It's at the paramedic's discretion. The control, what they're comparing it to, is the first two attempts at vascular access are with an IV. Again, after that, you can do what you want to. Because this is an intention to treat paper, the patients are analyzed in the group they were assigned to, not necessarily the vascular access that they got. Their primary outcome was 30-day survival. Now, if we talk about the patient characteristics, one of the things about vascular access, one of the reasons that we like interosseous access, is that it is easier. It has a higher first pass success rate. Well, because we're doing an intention to treat analysis, that means that we analyze the outcomes of the patients in the group that they were assigned to, not the group that they actually got. Well, let's take a look at these two groups. In the interosseous group, there ended up being about 3,000 patients, also about 3,000 patients in the intravenous group. However, in the IO group, 94% of patients got an IO. The vast majority of those were proximal tibial, about 73%. However, in the intravenous group, 65% of patients actually got an IV, while 33% of patients got an IO. And that is because they failed with the first two attempts at IV access and then defaulted back to their rescue, which was IO. And again, even though 33% of patients had an IO, they were analyzed in the IV group because of intention to treat. Now, in the IO group, the vast majority were proximal tibial, as I said, 74%, 17% proximal humerus, and then somewhere around 4% were other. IVs, like you would expect, vast majority was peripheral access. Now, the whole point behind IV or IO, the whole concept that an IO might be better is that it might be faster, and time with epinephrine seems to matter. The faster you get it in, the better the outcome. So if you can start an IV or if you can start an IO and get the epinephrine in faster, then theoretically you should have higher survival. If you remember back in Paramedic 2, one of the big criticisms was how long it took to get the epinephrine in, and it was 19 minutes, if I remember correctly, and I'm pretty sure I do. Now, that's 19 minutes from the emergency call, not from on scene. So keep that in your head. If we're thinking time to medications matter and IOs might be faster, then the first thing we'd want to see is how long did it take us to get vascular access in both of these groups. And as it turned out, there was no difference between the IV and the IO group. Now, specifically, the time to get vascular access in the IO group, 12-minute median, IV, 12-minute median. Not shocking that there was no difference there. How long did it take to get the first drug in? 14 minutes in the IO group, 15 minutes in the IV group. That was not statistically different. So, no difference in how long it takes us to get the medication in. So that's the first big thing that we have to think about. So let's take a look at the results of Paramedic 3. So first, they wanted to get 15,000 patients in. They weren't able to. They had to terminate because enrollment was much slower than they thought. And well, they ran out of funding, and this was a pragmatic trial. They wanted 15,000. They got 6,000. The primary outcome, well, before we do that, let's talk ROSC. So any ROSC at all, and I grant you, we probably don't care about that, but let's hit this because, well, this was significant. 36% ROSC in the IO group, 39% in the IV group. That was statistically significant. 0.86 adjusted odds ratio, 14%. Is that right? Yeah, 14% lower adjusted odds ratio with a confidence interval of 0.76 to 0.97. Sustained ROSC, meaning they still had ROSC at the emergency department arrival. That was 22% with IO, 25% with the IV. Adjusted odds ratio, 0.85, 15% lower odds of sustained ROSC with IO versus IV. Confidence interval 0.74 to 0.98. Now, that was statistically significant. I think most of us would argue it's not clinically significant. And fortunately, that wasn't their primary outcome. What was their primary outcome? 30-day survival, 4.5% with IO versus 5.4% with IV. Adjusted odds ratio, 0.94. Confidence interval, 0.68 to 1.32. Your confidence interval crosses 1. 1 is no difference. This was not statistically significant. Survival to discharge, just the same, not statistically significant. Your adjusted odds ratio was 1.00. I love, if you're going to be no different, you might as well go all in and be no different. 1.00. Love it. They also reported functional survival at discharge. That was 2.7% with the IO, 2.8% with the IV. Adjusted odds ratio, 0.91. Again, both sides of the confidence intervals on both sides of 1. No significant difference. Now, the one thing I have to say about this, because I can hear everybody saying their overall survival is 4.5%. That is horrible. Why are we paying attention to what these Brits are doing? Well, think about the population. They got enrolled at the time that they needed to give the medication. So that excludes the patients that never got a medication at all, meaning the ones most likely to survive the witnessed arrest with shockable rhythms that convert after the first shock. So don't be judging. These are not the patients most likely to survive. All right, so that's it. That's Paramedic 3. No statistical difference. But wait, there's more. Let's get to the IV-IO trial. This also was a multi-center study. This one was done in Denmark. It was a Danish study. Again, it was open label. Still haven't come up with a way to hide whether you're using an IV catheter or an IO needle. Again, this was also intention to treat. Also, the population, adults in out-of-hospital cardiac arrest who needed medications. They excluded the same patients, but they also excluded trauma. Paramedic 3 included trauma. The IVIO excludes trauma. The intervention, what are they comparing? Again, the first 2 attempts with an IV compared to the first 2 attempts with an IO. And then here's the cool thing that IVIO did is if you are randomized to the group that got an IO, then you'd go through a secondary randomization for the location of the IO. You would go humeral or tibial, again, randomized. The outcome here actually is a little different than paramedic 3. It's not survival at all. It is sustained ROSC at ED arrival. Well, let's take a look at the characteristics. So this is also a slightly smaller trial. The IO group had 731 patients assigned. IV had 748. The first pass attempt, if you will, success in one attempt in the IO group was 85%. It was 61 in the IV group. This is what we would expect. IOs are easy. Easier, I should say. Still not foolproof. Success within 2 attempts, 92% for the IO, 80% for the IV. And again, intention to treat, you're going to be analyzed in the group you're assigned to. If you don't get your chosen access, the one you're randomized to in the first 2 attempts, then it is paramedic choice. Most people with IV will then switch to an IO. Okay, how long did it take to get that initial vascular access done? 14 minutes in both groups. So again, no difference. How long until epinephrine is administered? 15 minutes. 15 minutes median time. And again, that is from whatever the Danish 911 system is. So very similar to paramedic 2 and similar to paramedic 3, but there's no difference. It turns out that easy rapid IO, I don't know why, but it doesn't seem to be saving any time. What about the results? So their primary outcome, again, sustained ROSC at ED arrival. It occurred in 30% with the IO group versus 29% in the IV group. The difference was 1.6%, but that crosses 0. We're talking about a difference here, not an odds ratio. So 0 is the point of no difference. This is not statistically significant. They do report on survival. 12% survived in the IO group, 10% in the IV group, 1.6% difference, not significant. Same with favorable neurologic outcome, 9% in the IO, 8% in the IV group, no significant difference. Now, you notice here that your ROSC rate is higher in the IV-IO trial and survival is higher. You might be tempted to say, well, the Danish system must be doing something different than the British system. Yeah, the trial is excluding trauma in the IV-IO group, whereas it was including it in the paramedic 3 group. And we all know that the outcomes for traumatic arrest are lower than they are for medical arrest. Now, there was a nice forest plot. Love me a good forest plot. The IV-IO trial has a nice plot that does all of the subgroup analyses trying to see whether there was a difference. Was there a difference in shockable rhythms versus non-shockable rhythms? No. How about witnessed arrest? Bystander witness, EMS witnessed, unwitnessed? No damn difference. Bystander CPR? Nope, none. Men, women? Nope. No difference any way you slice and dice it. So, where does that leave us? Well, now we have 2 randomized control trials that tell us there is no difference in outcomes and no difference in vascular access time or time to epinephrine with IV versus IO. Now, I could not find the sensitivity analysis where they did this in the as assigned group, as randomized group, or the per protocol group. I don't know whether there was any difference when you look at what they actually got versus what they were assigned to get. I can tell you an intention to treat is the right way to do this. I think overall what we're seeing here is there's no difference. Now let's go back to the Heart Association, shall we? Their recommendation in 2025 is the same as it has been in the past, go with IV first. If you're not able to get it in rapidly or you're not able to get it in successfully, then it's reasonable to move to an IO. They came out with that before these two trials were published. I think if they had these two trials, they would probably say, do whichever one you were able to do. Look at other things like cognitive offloading or skills capabilities, whatever the issue is. Local issues probably outweigh the evidence on this, because the evidence says right now, with good, well done RCTs, it doesn't matter. So, going back to this question that Latimer had, Latimer said their protocols, which again were written long before these trials came out, stresses early IV access and early epinephrine. So I think we have answered the should we do IV versus IO. Just doesn't matter. Do whatever you want to do. What we don't have, though, is a question to time to epinephrine. We don't have an answer from these trials because there was no difference between the IV and IO group. That doesn't mean there's not a difference in time to epinephrine. There is a substantial amount of observational evidence that says the faster you get the epinephrine in, the better. We have a tendency to think that is primarily in non-shockable rhythms, but it turns out there is some evidence that it also matters in shockable rhythms. Now, going back to the Heart Association and the recommendation that I'm not a big fan of is their increase in the level of evidence for epinephrine 1 to 10,000, 1 milligram every 3 to 5 minutes, just like we've been doing it since 1906 when Krill and Dooley killed some dogs and gave them epinephrine. They said because Paramedic 2 showed a 0.8% increase in survival with no difference in neurologically intact survival, that is the best evidence you will ever get. You must use it. Increased level of evidence. I don't think that's certainly not my read of the literature. My read of the literature is there's a signal here that epinephrine matters. The challenge is most people don't care about survival. They care about functional neurologic survival. But you can argue, and I have certainly heard this argument, if you can give epinephrine and it gives you 0.8% increase in survival, you can't have functional survival without survival. Take that 0.8% and run with it. The challenge is that there was no difference among all patients in neurologically intact survival. But what happened to the survivors? And this is where I really think the Heart Association missed the punchline, the true punchline of the paper. Most people would rather be dead than neurologically devastated. Surveys are telling us what our patients want, what they value. They said, I would rather be dead than neurologically devastated. And as a matter of fact, there is something called a minimum clinically important difference, MCID. When surveyed, people said they really want to see at least 2 percentage points better survival with an intervention if it comes with a risk of neurologic devastation. Remember, Paramedic 2 showed 0.8%. That is, even for an Aggie who's bad at math, less than 2%. Well, what about neurologic devastation in survivors, the thing we fear most? It was double in the epinephrine group. That's the thing that I think we're very worried about. Certainly what I'm very worried about. But getting to Latimer's point, I don't think we can get nihilistic about this and say epinephrine doesn't matter at all, because Paramedic 2 did take 19 minutes to get there. If there were a way for us to get epi in faster, might it make a difference? And it certainly seems to. Salt Lake City, with their before-after study with IM epinephrine, got it in faster and saw better survival. Well, what about the total amount of epinephrine given? It turns out it doesn't seem to matter. Certainly, we know high-dose epinephrine, no difference. That's not our goal. North Carolina did a couple of one-and-done studies that showed less ROSC with 1 milligram. We knew that, but that's not what we care about. And they showed no difference in survival. Unfortunately, they didn't show neurologic devastation among survivors, because I think that might be where the advantage is. So bottom line on this, get the drug in however you want to get it in, IV or IO. Either one is reasonable. There's no difference. 2 randomized controlled trials are telling us this. And until we get better evidence, do everything you can to get the epi in faster. After that, it's a crapshoot. We don't know what to do. We don't know whether we should continue giving it. We don't know whether we should give it as an infusion. There's just not good evidence on that. I have opinions, but, we all have those. So that's what we have for this episode. Latimer, thank you so much for the question. Great question. Love it. The timing was perfect. And I just have to put one more plug in. If you get a chance to come to Iceland, definitely do it. So many cool things. It's a beautiful country. Thank you all very much, as always, for listening, and thank you for what you do every day. Take care.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Firedog production. Visit flightbridgeed.com for more information.